afternoon, everybody, and thank you very much to AlzChem for inviting me. It's a pleasure and an honor to be here in such a prestigious meeting. I will talk about creatine in statin myopathy and in sarcopenia, and to begin with, doesn't work. Okay. These are my disclosures, and this is who funded this research, and I have founded an academy spin-off to create and market creatine-based supplements. Let's talk about creatine and statin myopathy, and let's introduce what the interest of this is. Now, my interest in statin myopathy stems from my interest in cerebrovascular disease, which is a stroke, and to prevent occurrence of stroke, cholesterol must be very low, among else. So just to tell you how important is the subject we are talking now, we have here some data. This paper, which was published in Lancet, showed that lowering LDL cholesterol is low-density lipoprotein cholesterol, and this is the cholesterol which penetrates the arterial wall and causes arteriosclerosis. If you lower LDL cholesterol by 1 millimolar per liter, you lower the risk of stroke by 20%. So going down this little prevents 1 stroke out of 5. And the same occurs in myocardial infarction. You see in all age ranges, those which have the highest concentration of LDL cholesterol, the red line, are those who have the highest incidence of myocardial infarction. And the same data exist for limb arterial occlusion, which is one necrosis of your upper arm or your leg. So, especially in the last 10 years, 10, 20 years, it has become very apparent that a strict and aggressive lowering of blood cholesterol is necessary to decrease the incidence of all vascular diseases, whether in the brain, in the heart, or in the limbs. Now, to do so, of course, can you give me the next slide, please? To do so, of course, you have to exercise, to eat well, and all kinds of things. But when we speak of real disease, I mean of real arteriosclerosis, or real hypercholesterolemia, you have to resort to drugs. And speaking of drugs, statins, statins are the first line of lipid-lowering drugs. They are the first drugs that are trialed to decrease LDL cholesterol. Okay. Now, one major problem of statins is that statins cause muscle disease. They cause myopathy. People start having aching muscles. They start to have weak muscles. They start to have cramps. And very often, these symptoms are so annoying to you, to be mild, that people stop taking statins. Now, speaking of statin myopathy, you can range from pain and not much more to dramatic elevation of serum creatine kinase and major muscle disruption. The frequency of this condition is rather debated. In clinical trials, they observed about 1 to 3% of patients having this effect, but in the real world, it seems to be much more frequent, ranging from 10 to 13% of patients, up to 29 or 38% in some cases. Nevertheless, it is an undisputed fact that statin myopathy is a major cause of stopping statin assumption. Okay. Nowadays, the drug industry has developed many alternatives to statins. So if statins don't work, or if they must be stopped, patients do have alternatives. And here are the main ones. Ezetimibe, which is, it prevents the absorption of cholesterol, bempedoic acid, PCSK9 inhibitors, and RNA messenger silencers. The problem with these second-line drugs is that they are expensive. Here we have computed the cost of 1 month treatment in Italy. You see that the highest dose of atorvastatin cost 13 euros a month. When you go to ezetimibe, it goes 59 euro. Bempedoic acid 133, and all these are not very effective. When you go to the really effective, to the very effective drugs, this one costs 700 euro a month, and this one costs 1,000 euro a month. So this has led Professor Garattini, who is an opinion maker in pharmacology in Italy, to state that this kind of cost could result in hardly sustainable expensive even for developed countries. Just for comparison, we were discussing yesterday the cost of 1 month creatine treatment in Italy. Depending on what creatine you buy, you can go from 10 to 20, 25 euros a month, not much more. Okay, so why do statins cause myopathy? I'm not really an expert in this field, but my understanding, and that of many of my colleagues, is that we don't know. We published a paper summarizing some of the hypotheses that were made, and you see here a lot of papers in the field and what they said. It seems to me we don't know what statin myopathy is caused by. But we do know one thing, and that is that statins reduce creatine synthesis. This was first observed, or at least hypothesized, by Schumann and Cray, which we will quote later, and who were the first to use creatine to treat statin myopathy. They observed that in statin myopathy, there is an increased ratio of creatine to creatinine in the urines. So they reasoned that since there is a relationship between creatinine in the blood and creatine in the muscle, this disease could have been treated, could have been caused by a decrease of creatine in the muscle. They made this hypothesis. And in 2015, this scientist, whom I don't dare to pronounce his name, found that in liver cells, atorvastatin actually decreased the content, the synthesis actually of creatine. He actually measured creatine in hepatocytes, and he found that control hepatocytes had about 60 millimolar per liter creatine, while hepatocytes which were treated by atorvastatin had about half as much creatine. So this scientist actually demonstrated what Schumann and Craig had hypothesized a few years before. Not yet, sorry. And also it has been found that a special polymorphism of the AGAT gene, which is, as you know, the first step in the creatine synthesis, is associated with a reduced incidence of statin myopathy. Now, to be honest, this finding has been debated in the literature, but still it has not been refused, so it is still an active hypothesis. Now, I don't have to tell you that decreased creatine in the muscle is harmful for muscle function. The best evidence, I think, comes from hereditary diseases where creatine is not synthesized. And mice lacking the AGAT enzyme show decreased strength and muscular atrophy. And the same happens if you deplete an animal of creatine by feeding it guanidinopropionic acid. And this animal has, among else, a whole range of muscle dysfunction. Okay. I think it is interesting to note that lack of creatine impairs mitochondrial function. In fact, we made this cartoon, which is much less fancy than those we saw yesterday by Theo Wallimann. But anyway, in the mitochondrion, as you know, ADP is transformed into ATP and back and forth. Then creatine intervenes. It takes the phosphate of the ATP, transforming itself into phosphocreatine, and so forth and so forth. Now, the interesting thing is that if this wheel stops, this wheel as well goes to stop. So, if you have no creatine, you don't remove ATP from the mitochondria, and this is going to fail. I hope Theo agrees. And an interesting thing is that in all the theories that try to explain statin myopathy, as you see, altered mitochondrial function is almost always present. So altered mitochondrial function is certainly present in statin myopathy, and except I don't think it is clear why should it be so, but as I said, lack of creatine could, I think, well explain this finding. Also, as you know, creatine favors the development of, the differentiation of muscular cells. So this is the rationale for trying creatine in statin myopathy. The first authors to use creatine to treat statin myopathy were Schumann and Craig back in 2010. They were working in Cleveland, and they treated about 10 or 20 patients who were intolerant to at least 3 different statins. So just to make sure the diagnosis was correct, all patients had to be intolerant to at least 3 different statins. They gauge these myopathy scores that assess pain in the muscle, weakness of the muscle, and cramping on an analog visual scale, 0 to 10. This is a picture I made to summarize their study, and you see they, first of all, they stopped the statin and they loaded the patient on creatine, and at this stage they didn't have pain and the myopathy score was low. Then they introduced statin, and then and at the same time they added creatine. So these patients now were taking the same statin to which they were intolerant, but with creatine. And as you see, they didn't have pain and the myopathy score was low. To control their findings, they continued the statin but withdrew creatine, and as you see, they had statin myopathy. The myopathy score skyrocketed very high. Then again, they reintroduced the creatine with the same paradigm while continuing statin, and they found that the patient could take the same statin to which they were intolerant before. Quite surprising, this finding did not have much follow-up, went largely unnoticed, I think. So, we wanted to try one patient with this protocol, and we treated this 66-year-old woman who had a very complex clinical picture, you see here, and had 316 milligram per deciliter of LDL cholesterol, while the upper limit of normality is 100. So this was a very high lipidemic patient who needed to take all the drugs she could. So she had, before we saw her, she had to stop 2 statins. We reconstructed her medical history, and we found that she had taken atorvastatin, and she had both increased the creatine kinase and muscle pain. So she had to stop atorvastatin, and she was well. She had taken simvastatin, and again she had increased CK and muscle pain. And then she stopped simvastatin, and she was well, of course. And then we gave her the same simvastatin to which she was intolerant, plus creatine 5 grams a day. And as you see, she was fine. She had no muscle pain, and serum creatine kinase was low. So we were rather encouraged by this case report. And we started this very small pilot clinical trial. Okay. Here we have inclusion and exclusion criteria, which are kind of usual. You can read them here. And we also established the criteria for study withdrawal in case of adverse events. And I would like you to note that we, as a preset criteria for study withdrawal, we stated increase in creatinine value by more than 1.5, its upper limit of normality. As you know, there is a debate whether or not creatine is harmful to kidney, and I believe it is not, but still it is safe if you are a medical practitioner and you want to sleep well at night. It is safe not to continue creatine when your patients increase their creatinine blood values. Also, I think it is safe not to give creatine to patients already having a high blood level of creatinine. Again, I don't believe that creatine worsens or damages renal function, but just to be on the safe side, I think this is what we should do. The study protocol we used was the same as Schumann and Craig. So our patients were taking statin even if they had pain. So we stopped the statin for 1 week. During 1 week, we gave 6 grams a day creatine. Then they resumed the statin and they received 3 grams a day of creatine. The study went on for 4 months and we saw the patients each month. I draw your attention to the dose of creatine 3 grams a day, which appears rather low. Probably it is not so low. Anyway, the 3 grams a day stems, as we were discussing yesterday, from the fact that in Italy, the Ministry of Health recommends for each diet supplementation the recommended or maximal daily allowance, and for creatine they recommend a maximum daily intake of 3 grams. So again, if you want to sleep well at night, you better stick by this regulation. Except they say that it is allowed a dose of 6 grams a day for a maximum of 1 month. So we navigated within these limits, and this is what we did. We screened many patients, some were not eligible. Eventually, we found 13 patients who were eligible. Of them, 11 patients completed the study, 2 had to withdraw, 1 for unrelated conditions, not creatine dependent, and 1 for a critical increase of creatinine. This reminds us that when we treat these patients, we are talking of sick people. These are people who already have atherosclerosis, who already have had some vascular disease, so they are not healthy athletes or young, healthy people. They are sick people, and we should be careful to remember that. Anyway, in the 11 patients that completed the study, first of all, we found no significant changes in either serum creatinine nor in cholesterol. And this is important because some colleagues are rather worried, in an irrational way, I think, but they are worried by the fact that stopping the statin for 1 month may cause harm to their patients, which is not true because using our protocol, we did not find any change in cholesterol. The core of the results is this one. At the end of the 4 months, the myopathy score was significantly reduced. This is the myopathy score at baseline, and we found an effect immediately, and this effect persisted, and it remained statistically significant at the 4th month of treatment. And this is the same thing, except the graph shows these are absolute values and these are differences from baseline. So we found that, generally speaking, the creatine improved in a very significant way the myopathy of our patients. Quite interestingly, if we separate our patients into those who had increased the creatine kinase at baseline and those who had not, we found that creatine did improve a myopathy score in those who had not high creatine kinase at baseline. But it was either it did not improve or did not improve in a statistically significant way the myopathy in those that had an elevated serum CK at baseline. We believe that the reason is that, as you know, creatine kinase is an enzyme which is inside the muscle cells, and it spills into the blood when the muscle membranes break down. So increased serum creatine kinase is a marker of anatomical damage to the muscle cell. So probably when the muscle cells are already so hardly damaged that the creatine spills into the blood, probably then creatine either doesn't do anything or it does much less. But if you treat those patients before the anatomical membrane damage occurs, then you have quite nice results like you see here. So in conclusion, our data confirm that creatine supplementation is safe even in this population of elderly and frail subjects. It is capable of significantly improving the symptoms of statin myopathy, especially in the initial stages where CK is not yet elevated. And creatine supplementation is a feasible option to treat statin myopathy, and it could probably prevent the switch to the very expensive second-line drugs that we talked before. Then I would like to show also a couple of slides. I hope I'm still in time. Am I in time? Yes. Okay. We were kind of interested in creatine as a treatment of sarcopenia. We didn't do any experimental research, but we carried out a meta-analysis on literature data. As you certainly know, sarcopenia is a pathological condition. Sarcopenia, which, as you know, comes from the Greek words sarkos, meat, and penia means less. It has less muscle, less meat. Is not normal aging. I mean, we all lose muscle mass while we age. But this is not sarcopenia properly. Sarcopenia is a disease where the muscle mass is critically decreased and the force is also critically decreased, sorry. As far as I know, there is not a single unique definition of sarcopenia. But all definitions, all criteria take into account the fact that both muscle mass and muscle strength are decreased. It's a severe condition which reduces functionality, makes people at risk for fall, decreases their independence, and it worsens their prognosis. Creatine may counter sarcopenia, again, by a lot of mechanisms which we summarize in this slide and which we discussed in our review that is quoted at the bottom of the slide. So, since there are many studies on creatine and sarcopenia, we did a meta-analysis of them, and we used these three databases, PubMed, Web of Science, and Scopus. And I think this is somehow important because in the past 10 years or so, we have witnessed rather an explosion of scientific journals, and most of them are very serious. Many of them are less serious and less reliable in terms of peer review and so forth. So I think that if you stick to these three databases, you maybe lose some interesting paper, but you are certainly on the safe side, and you make sure that all the papers you include are rather reliable, I would say, at least by common scientific criteria. The search ended in August 2024, and we searched the two keywords, sarcopenia and creatine. We took into our analysis only controlled studies that evaluated as outcomes muscle mass and or muscle strength. So these were the two outcome measures we were looking for. This is just to say that we worked a lot, we screened a lot of papers, and we ended up with 14 final papers. All of them were randomized controlled trial, which evaluated muscle mass and or muscle strength as outcomes. So the outcome one was variation in body lean mass, and outcome two was leg press exercise. This is interesting because I think Darrell Kando yesterday was speaking of force in the upper limbs and force in the lower limbs. And it is quite interesting that all the papers we evaluated here were evaluating only leg press, so lower limb strength, which is exactly what Darrell said is not very affected by creatine. And we will return to this later. So this is the bottom line. Outcome one was very positive in our meta-analysis. It turns out that although single studies, as you see, were rather unconclusive, they didn't show one by one any statistically significant effect. By pooling all of them together, you do have a significant effect. And this tells us that creatine supplementation is, in fact, capable to correct lean body mass loss in these subjects. I'm sorry, I forgot to tell one important thing. All studies used as intervention creatine in addition to an exercise program. So all these patients had an exercise program, whether controls and treated. The treated patient had creatine in addition to the exercise program. So what this slide demonstrates is that creatine has an additional effect to exercise, or to put it better, increases and enhances the effect of physical exercise in improving muscle mass. As for the second outcome, there was no difference in strength. So by judging this analysis, it seems that there is no effect of creatine on top of physical exercise in muscle strength. It's quite curious that we speak of lower limbs strength, while yesterday we heard, if I'm not wrong, that creatine improves upper limb strength more than lower limb. So it is probably worth going back to this issue by evaluating not lower limb but upper limb strength. In conclusion, creatine is capable of increasing the effect of exercise in the treatment of sarcopenia. And I guess this is all, and I thank you for your attention, and I'm willing to answer any question you may have.